We have a presenter, Mr. Dr. Abid Hussain, who's a consultant podiatrist, and Tosif is moderating the session throughout the session. So without wasting any further time, I would like Dr. Abid Hussain to start with his presentation. Thank you, Dr. Abid Hussain.
Thank you very much. Thank you very much, Ahmed, for your kind words. And thank you very much for inviting me today to talk about an interesting case study. So first of all, if I am talking too quickly, please, or if you cannot hear me correctly, please type in the chat and I will adjust my voice and my tone accordingly. This case study is diagnostic red herrings and rabbit holes. And the reason why I called it this is very often when you've been in practice for a long time. So I've been in practice for 30 years. Very often when you've been in practice for a long time, when you see a patient presentation, you automatically go on to autopilot and you assume that something is going to be that particular pathology. And the idea of this presentation is that I introduce you to the concept of red herrings, which is basically, we call it red herrings when we get taken off the path and we see something else that we shouldn't be focused on. And I want you to foster that idea of creating an open mind when treating patients. So let's move on to the first slide.
Can you be a little bit loud and can you be a little bit clear, because people can't hear you very clearly?
I will try and talk a bit louder. Is that better?
Everybody, please let us know if this is a bit better.
I'll try and talk a bit more louder. So this was a patient that presented in clinic. Now, I'm going to make this interactive. So I'm going to show you a video. I'm going to talk through the video, then I'm going to ask you to put some messages into the chat box. So a patient presents in your clinic, and is the video playing, Tosif? Yes?
I'm keeping an eye on the chat, yes.
Yeah, so what you can see is on his left foot, he's unable to do a heel raise. So he's really trying really hard. I'm going to turn the camera around in a second, and you'll see again on his right foot, he can go up and down very easily. And on his left foot, he's really activating the muscles in his feet and his legs, and he's unable to go up and down. So let's see if we can make all your minds work. I think it's 8 o'clock in Pakistan at the moment. So give me a couple of possible pathologies that might lead to that. Feel free to put it in the chat box, and then I'll talk about the case itself. So see if let me know what anybody types in.
I will. I think these physios are very shy people.
They can't be shy.
Plantar fasciitis is the first one. If Sahel, well done for starting this off.
Next. What else? Come on, don't be shy. There's no right or wrong answer. Well, there is a wrong answer, but...
Soda Hussain says it's PTTD. That's a good answer. Problem ankle, leg length discrepancies, weak calf muscles, sinus tarsi syndrome.
Okay, so who said PTTD?
That was Soda Hussain.
Soda, I want Soda to type in. So what stage of PTTD would that be? 1, 2, 3, 4. Which stage? Come on.
She says 2, I guess.
Okay. All right. So let me not be so cruel. Let me carry on. So let me talk about what are the possible reasons why, if a patient presents like this and they are unable to do a single leg heel raise, there are multiple different causes. The first thing that should come through your mind is an Achilles rupture. Okay. You can also get a triceps surae, which is there's like 3 muscles in the calf muscle that can lead to, if you have a rupture there, that can also affect the way that you do a single leg heel raise. Regarding posterior tibial dysfunction, PTTD, it would be stage 3 or 4, Saha. So that would be, because in stage 3 you would have a flat foot deformity, would be a rigid hindfoot valgus rather, and severe arch collapse, and that could lead to it. There's other causes as well, like S1 nerve root entrapment in the back, possibly sural nerve entrapment that could possibly affect it. So I'll try and go forward. This was the presenting complaint. The patient was unable to do a single leg heel raise on the left foot. He was a type 1 diabetic, okay? There was a familial history of high cholesterol. He had hypertension, family history of strokes, but he was a consultant pediatric dietitian, okay? So he's a type 1 well-controlled diabetic. His HbA1c wasn't too bad at all. He was on a statin, and his blood pressure was all right, 135/80, and he was taking some Ramipril. Because he was a consultant, there was shared decision-making in the management of the patient. When a patient is using statins, you need to understand that it is associated with tendinopathies, okay? There is evidence regarding it. It can also be associated with type 1 and type 2 diabetes. So this was what happened. Prior to 17th of June 2017, this patient could do all of this. He used to love running half marathons. He plays cricket. He was an avid batsman. He used to love cricket. That's what he really wanted to go to. He would do heavy deadlifts and squats. On the 17th of June, he had a closed fracture, which was a Weber A fracture. I'm going to talk about Weber A and B fractures in a minute. So because of that, there was a risk of damage to the anterior lateral ligaments. He had some conservative physical rehab with a physio for 3 to 4 months. Then come in July 2017, he had an MRI, and it showed a minor strain to the ATFL, which is anterior talar fibular ligament, and the AITFL, which is anterior inferior tabular fibular ligament. He had intrasubstance thickening of the ATFL. So let me briefly, I'm not going to talk about this too much. So he had a Weber A fracture. Now, when you have a Weber A fracture, this describes a fracture of the lateral malleolus distal to the syndesmosis, okay? Normally, the tibular-fibular syndesmosis is still intact. The deltoids are still intact. And it's normally below the level of the tibial plafond, which is the syndesmosis. As you get a type B fracture and type C, this is slightly different. So a type B, it will be at the level of the tibial plafond, but you may also have fractured the media malleoli, and the deltoid ligament may be torn, okay? I won't talk too much about type C. Okay, so this is what happens. In October 2017, he's getting a lot of knee pain when he's running, lifting weights. So he went to see a podiatrist. He went to see a couple of podiatrists in Birmingham, actually, here in the UK, and they kept giving him insoles, because this is what podiatrists do. They just give insoles, because that's the answer to everything. But it didn't work. So he was still getting noticeable pain. Then from October 2017 to July 2020, he was wearing orthotics, but he was getting hip pain. He was getting lateral left hip pain as well. He was getting lower back pain when he was doing his activities. And so he went back to another orthopedic surgeon. So this was in June 2022. Now, I am going through this because there's a lot to cover. So he had another MRI number 2 of his left ankle, and it showed a small calcaneal spur. It showed that the ATFL, the anterior talar fibular ligament, may have been torn, and he had slight thickening of the tibialis posterior tendon. So when you look at the MRI scan, it says a normal Achilles. He had a calcaneal spur, and he had trace fluid in the tibialis posterior sheath. Thank you very much for listening to me. I'm open for questions. Any questions you have, feel free to ask.
Dr. Ifra wants to know, what is a Weber A fracture and B fracture again, please?
So a Weber A fracture. So this is an ankle fracture. So This is normally dealt with by orthopedics. You can get a Weber A, Weber B, Weber C fracture. So here, when on the 17th of June, when this occurred, he had a closed Weber A fracture. So this is normally dealt with by open reduction and internal fixation. So you get screws and a plate that is put in there. A Weber B fracture is slightly different. The tibia, the actual syndesmosis might be torn in a Weber B fracture. So your AITFL, your PITFL, and there's an interosseous membrane that comes between both of them. That could be torn in a Weber B fracture. But I could, that's a whole, the Weber A, B, and C fracture is a lecture if Ahmed asks me, I'll give another lecture just on those.
I think Ifra, this is a very good question, and I think this is something which you should go and investigate and read up on. I've sent you a link on the chat already. Just have a little read through it and do some research regarding it. Another question, Dr. Saab, where was the bone found? And how did that, so a similar question linked to that is that how did this fracture have affected FHL?
So when you have a Weber A or Weber B fracture, you could have a small fragment of bone that comes off, okay? So, which is what exactly that happened here. They had a 1.1 to 1.5 centimeter fragment of bone. So often this is called an os trigonum. That's actually not true. And a pure os trigonum is a accessory bone that a lot of people have and doesn't cause an issue. This was found at the posterior aspect of the FHL just before the Stidus process. So as the video that I showed you where he was showing where he removed all the scar tissue, this was formed just as the FHL goes at the back of the talus. Okay, so it slings around the back of the talus. It was found just there. Any other questions?
Aisha says that in Pakistan, we never get a deep diagnosis. Aisha, in terms of getting a deep diagnosis, this is exactly why we are running these webinars. And this is exactly why we are sharing these knowledge with all of you guys. So you guys get educated and learn about these things so you can perform a deep diagnosis. And here I would actually add, we've got another forum which we're going to be introducing in a short while, which is called Physio Gurus. And again, the purpose of that is to share knowledge. You can ask questions to people around the world who are renowned in the speciality that they are in, so that they can answer these questions, so you can answer and do deep diagnosis yourself. Right, Physio Gurus is a forum which we are introducing with regards to sharing the knowledge. This is a platform where we are hoping that all these potential individuals can come and register. There is a registration form which is free to join. Once you've joined this, what we are going to be doing is that you can share your knowledge, you can ask all the relevant questions, and somebody from the panel will be able to share the answers. And it's an effort to spread the knowledge. I think this will be covering predominantly podiatry, physiotherapy, and ultrasound. Any musculoskeletal related questions will be answered here. So feel free. If you remember, please register and ask lots and lots of questions. There's going to be a lot of very knowledgeable people who are going to be who will be able to answer these questions for you. So if you can actually see, there's a forum with this diagnostic ultrasound, sports podiatry, sports physiotherapy, sports psychologist, sports nutrition, manipulative therapy. So there's lots that we're going to be basically going through. So please join, register. I think that's pretty much it. Thank you ever so much, Dr. Abid, and everybody else. There was 82 people who joined here. So thank you ever so much for joining. I know it's late at night there. So yeah, thank you ever so much.